Welcome, everybody. And again, thank you for listening in on today's session. I'm John Lester, and I do some work with the Center for Collaboration, Motivation, and Innovation, a nonprofit founded in BC with the mission of fostering empowered partnerships, building helping skills, and creating responsive systems that improve health and well-being.
And hello, everybody. I'm Bruce Hobson, and I've worked as a family physician in Powell River for 35 years. And I work with a number of provincial organizations in BC, including CCMI, Patient Safety and Quality Council, and Doctors of BC Practice Support Program. My passion is adult learning and continuing professional development.
Today's webinar is about integrating self-management approaches and principles into your practice, and doing that using quality improvement methods and science. This webinar is made possible today with the support of Patients as Partners, an initiative of the Ministry of Health in the province of British Columbia. And before we get into some of the concepts, Troy is going to review some of the features of this GoToWebinar platform for you.
Thanks, John. And I just wanted to make the blanket statement that my office is under construction today, so if you hear any extraneous noises in the background, I do apologize for that. Anybody who has been on these calls in the past should have this pretty well in memory. This is what your screen is going to look like. You'll have the GoToWebinar viewer on your left, and that's the bigger box, and you'll be able to see the PowerPoint being displayed there. On the right, you will see the GoToWebinar control panel. That control panel has a few options that we'll use today. The first one is going to be the expand and collapse feature. So if you're looking at your screen, it doesn't look like what we're looking at on the slide here. You may need to expand the control panel so that you can see the question box and some of the other features that are available. John, if you could go to the next slide. And so here's a close-up view of the GoToWebinar control panel. And as I outlined briefly, the orange button is the expand and collapse. And that's going to open up the control panel so that you can access some of the features. The main feature that we're going to ask you to use today is the question box. And the question box is really handy if you have any kind of technical problems, if your audio is a bit weird, if your video isn't working, you can put those questions in there and I'll be able to field those questions, answer them directly, or forward them on if it's pertaining to the webinar. So if it is a question about the webinar, or if it's a comment about the webinar, if you're thinking something during the webinar, please do. We can't urge enough, put your comment in there. It's really helpful. It kind of makes things a bit more collaborative, and we really enjoy having your questions dropped in there. So at the end of the webinar, we'll have some time, and I'll forward all those questions on, and the presenters today will be able to answer your questions, or at least give you some suggestions. So I think that's it for me, and thanks everyone for joining, and John, back to you.
So thanks, Troy. It's actually Bruce here right now, and I have to apologize too. If you hear some strange tapping in the background, it's not your computer and your audio. There's a bird trying to get in my window and make a nest somewhere, and so I apologize for that. Anyway, the presentation today will provide an overview of self-management and self-management support, and we'll cover the following learning objectives. We're going to explain how the model for improvement is used as a method to integrate self-management support into practice, describe the link between changes in practices supporting SMS and provincial strategic priorities, and then give some examples of changes, some actual self-management support projects that can be tested locally. And on the next slide, we're looking at, as mentioned in the previous webinars, the Ministry of Health has 5 strategic areas of focus, and this webinar is part of the work towards an overall improvement in the quality and sustainability of the BC healthcare system. These quality improvements are both an experience of care and better health. And the focus is to work across those involved in healthcare in the 5 areas that you can see there. Improving access to primary care through primary care home model, reducing demand on hospitals by improving care for seniors, reducing demand on hospitals by improving care for those with mental illness and substance abuse issues, and improving access to surgical services and procedures. And finally, near and dear to my heart, improving delivery of rural health services. In a previous presentation, you'd heard about the stepped care approach to self-management support and how the concepts in self-management support are useful for all addressing the ministry's priorities. And in this presentation, we're going to talk about how to use QI methods to put self-management support concepts into practice, ensuring that action is taken towards addressing the ministry's issues. And if we're on this slide, this is just showing how self-management and self-management support contribute to the Institute for Healthcare Improvements Triple Aim that has been adopted in BC. So using the reliable methods to integrate them into practice helps ensure that they have the effect on the system that we're all expecting, and that there's especially important for sustainability. So in the policy document, a patient-centered care framework, the ministry states that patient-centered care puts patients first and at the forefront of their health and care, and ensures that they retain control over their own choices, makes them informed, make informed decisions, and supports a partnership between individuals, families, and healthcare providers. And so patient-centered care incorporates all those things such as self-management support, shared information making, enhanced experience of care, improved information and understanding, and advancement of prevention and health promotion activities. Whenever we think of patient-centered care, we also need to think about family and friend caregivers, and also caregivers in the community. Patient and family-centered care contributes to the goals of the Triple Aim. Many aspects of patient self-management support are part of patient-centered care. And, you know, I think key and why I so strongly believe in this is that when I first started doing self-management support in my practice, it was probably the single most useful thing and gave me the most satisfaction of anything that I've done in my practice in 35 years. And engaging in improvement work is another opportunity to involve patients and families. And we'll discuss some of those opportunities when we look at who should be involved in coming up with and testing new ideas for improvement. So the slide that you see here is from a GPSC presentation about the new primary healthcare and integrated healthcare models. The General Practice Services Committee, GPSC, is a joint committee of Doctors of BC and Ministry of Health. Also has representation from divisions of family practice and health authorities sitting at the table. They have presented a plan for co-creating the future of integrated care. And this new plan for the patient medical home and primary care home provides supports for patients and families and links with the specialized services, and is consistent with the stepped care self-management support model. And this is that model that I just mentioned in there. And as discussed in previous webinars, self-management support can be stepped up to meet people's needs. And as you go up the steps, the topics at the lower level will still need to be addressed. Today's webinar addresses quality improvement, which is on the second step. And this is based on the foundational step beneath it of diversity, cultural competency, health literacy, and engagement.
So let's do a quick,
John.
Yeah, let's do a quick review of the process. And some of you are familiar with it, or most of you may be familiar with it. But Mike Hindmarsh had walked through it in the Quality Improvement Fundamentals webinar. The model improvement was developed by Associates for Process Improvement. And it's really simple in concept. It's got the 3 questions that can guide improvement work, and then the testing cycle, which helps us learn about what it is we're actually making changes to. So you'll be continuing to use this model as you continue to test and implement changes to self-management support in your local systems and in your clinical service delivery. The quality improvement journey begins with recognition that there's room for improvement in your system. and an identified unmet need or gap. And Bruce, you had mentioned that, once you started doing this, you realized that this became really useful and there was obviously a gap. So this may happen after conducting some root cause analyses, doing some baseline measurements, talking with your stakeholders, mapping out some important processes, or just getting a sense of how things are really working and how they could be better. You might have some hunches and you act on those. So next, the quality improvement team or your practice team or care team develops an aim statement. So that's question one. And this is tied to a clearly defined set of measures that will be used to monitor the amount of improvement possible, but also the progress towards your aim. So you probably will then start to use an identified change package, and we're going to explain that a little bit more in a few minutes. And that contains ideas for testing, but also it leaves itself open to ideas from the team and other sources of ideas for changes. So it's really flexible and adaptable to your local situation. The ideas then get tested under various conditions to prevent failure during implementation. And so really improvement happens through these many small but persistent tested steps, and also in a planned direction.
And the beauty in this, John, is that this is the same model that has been used with the practice support program with physicians. So they understand this kind of language and understand this model.
Mm-hmm. Mm-hmm. Even though just historically, when this got brought to healthcare about 30-some years ago, people said, wow, that works for industry, but maybe not for us. And now, like you say, we have thousands of examples of people applying this and many local ones. All right, so let's look at the first question again. What are we trying to accomplish? So this is really about determining what will be the focus of your improvement efforts. It's the first step. What's your population? What will be your specific process? How are you going to get, or what certain level of service within a system do you want to achieve, etc. It's really focusing in on that. What is this going to be about? So what are we going to accomplish? A quick reflection is what you're trying to accomplish. Is it practical? Is it meaningful? Does it have clinical value? Does it have a value proposition associated with it? So look, thinking back to the triple aim, is there actually a system cost effect so that we can say, yes, we're delivering this in a way that's affordable? And then, of course, is it measurable? Can we actually measure success? So just a quick checklist for your aim. When you write it down, is it aligned with your organization's mission, vision, and values? Has it been developed by stakeholders, collaborators, and of course the people on the team that are going to be doing the work? SMART goals, is it specific, measurable, actionable, relevant, and do you have a time frame associated with it? So in the work that we're talking about in this initiative that we're helping you support through Patients as Partners, the time might be March 31st, 2017. And can you communicate your aim easily to others? What's your 1 minute or 10-second elevator speech? What is this about? Can you all be on the same page that way? So let's just look at an example, and it was presented to you in the QI fundamentals. But let's look at developing a good aim statement. If we assume that you've been tasked with a project, which you have, and that's to address patient-centeredness for 4 of the 5 ministry priorities. So improving access to primary care using primary care home model, reducing demand on hospitals by improving care for seniors, also reducing demand on hospitals by improving care for those with mental illness and substance use, and improving delivery of rural health services, a topic near and dear to Bruce's heart. Let's look at this. So the British Columbia Coalition for Patient-Centeredness will improve patient self-management with a pilot population of 100 individuals with chronic disease in the ABC program over the next 6 months. So there we have the time frame. Work with one care team, train providers in a variety of SMS techniques that increase patient confidence when managing their health. There will be an emphasis on building brief action planning into the clinical visit. The primary outcome for this pilot effort will be to increase patient confidence by 50% over baseline. And there are other measures as well. So they may include reduce urgent care and ER use and increase provider job satisfaction. So there we're hitting on the provincial priorities, triple aim, have time frame built in, talking about the population, and also what the outcome measure will be. So there's a lot of things in there. So we write all these things down. We have some ideas of what we want to work on. We have a method that we're going to use. We understand the population. Now, how do people know what's going to happen? And what we're showing you here is an improvement charter. And the improvement charter just captures all of these thoughts at the outset of your project. All right, so it has a place to put in the answers to the questions in the model. But it also has what you expect to achieve, like what will be the outcomes of doing this improvement work? Why is it important to work on this now? And then also, we like to add in, and not all charters will have this, but what are some things that you have to keep in mind as we work are? And for some of you, it might be bringing in community groups. It might be the cultural diversity aspect of your self-management support. So what you have to keep in mind can really be brought to the local level. And then, of course, we have a place to put down the key measures for you, which we'll get into a little more detail on. So you're looking at the imperatives, the benefits, the goal, and guidance and scope, but also how you'll know that the changes are an improvement. Which brings us to the second question in the model. How will we know that a change is an improvement? And really, measurement is the way to know if they're really making an improvement to the system. Otherwise, it's just change. So let's quickly review. This, again, is a review from the fundamentals. We're talking about looking at, for your project, a family of measures, which is 5 to 7 or 8 measures, and they give you an overall view of your system performance. Outcome measures are directly linked to your aim. They're the level at the change to the system that you're trying to achieve. So for instance, it might be to produce better population health if you're looking at clinical, or it might be to increase in a specific population the overall confidence of the patients to make decisions or take action. Process tell you that the system is running effectively, and they usually contribute to the progress towards your overall aim. And then balance measures help you understand if the changes you make are actually working against your goals, aims, and objectives. So are they is the work having an impact on the system that's opposite of what you intended? So just a couple things about measurement in general. Helps answer your questions. You usually start out with some questions. If we do this, will it have this effect? Helps understand your progress towards your aim. Helps you compare if you're doing some tests and locally it's across different sites. Are the changes making the same contribution or having the same improvement? Also lets you identify unexpected outcomes, and then let you know if your aim has been achieved.
And I think one of the things that I certainly see with a lot of projects, John, is that a lot of times we get caught up in the process measures, measuring the things that we're expecting people to do or that we've taught them or that we've implemented, and not measuring the outcome measures as much, because sometimes we just don't have the ability or an easy way to do that. And so we make an assumption that the process measure, is somebody using a questionnaire consistently as being a surrogate for a good outcome. And I think the caution there is put the effort in to working on developing and being able to measure those outcomes that are really important in patient care.
Yeah, great point, Bruce. And I put up an example here on the slide where in practice we've got an aim of using brief action planning as part of discharge planning, with 100% of patients using it by March, or receiving, having it part of their discharge planning by March 31st, 2017. So yeah, you'd have an outcome measure. Patient action plan is part of every discharge plan by that date. And also the confidence measure is another outcome measure here. So you're looking at overall, are they confident in fulfilling the plan? And as you're saying, Bruce, here's a couple process measures. And the second one is percentage of staff and providers trained in brief action planning. I mean, that's a great start, of course. People need the skills to be able to put this into practice. So many of you on the call are working in settings and systems where this has been a focus, is getting people trained. But as Bruce mentioned, it's a process measure. Your overall aim is something different. So thanks for pointing that out, Bruce.
You know, and I think too in this example, in the outcome there, you know, it's great that patients have confidence, and the challenge is this instituting this process actually having effect on patients following through with their plan, and that their plan is making a difference to their condition. And that's where people are challenged. So how do I measure that? You know, where am I going to go to get the data for that? And I think it's always something to really consider, that even though it's tough, it's sometimes the thing that's most relevant.
Right. And then, of course, the other part of that is, all right, we've got these measures. Oh, they sound great. We think that if we measure this, this will tell us about what we're doing and whether that's improving things. But then the question becomes about your measurement processes themselves. Who's going to measure this? When is it going to be captured? How will it be captured? Who records the data about the action plan and the discharge plan? Where can it be recorded and displayed for staff and for the patients? And when will the team take the time to stop and look at that data, analyze it, and make some decisions accordingly? So just in terms of process, percent of whiteboards with patient goals listed. We can walk by and observe that, but somebody actually has to take the time to go around and see that at a certain time every day and note that somewhere, document it for your study of your testing. And so that's something that the team has to sit down and discuss. What will be our measurement process? And I would suggest sticking with the simplest approach that you can to begin with. And I was in a conversation yesterday with a group where they determined that, yes, taking a piece of paper and a pencil and having the person closest to the work walk around and do tick marks to count is often the easiest when it comes down to it. Although it sounds so technologically unsophisticated, sometimes it's the best approach to begin with. All right, so let's look at the third question. What change or changes can we make that result in improvement? So changes and ideas are what is needed to start to begin testing for your improvement. We talk about the term change concepts and ideas, and a change concept is a general notion or approach to change that's been found to be useful in developing specific ideas for changes that lead to improvement. It's important to recognize that many of your ideas are rooted in concepts that come from knowledge and associated thought processes that apply the concepts to the aim at hand. So self-management support and the stepped care model for SMS have been tested and trialed in so many different settings, researched, evaluated. So we are starting with some known concepts, some evidence-based concepts. But in short, like, we need to be cognizant of why and how an idea is generated, so we don't end up testing just random ideas. It's also important to recognize we bring our biases, our own assumptions, and our own mental models into our ideas, that we need to stop and identify where possible. So by testing in a systematic way, we can actually see if evidence matches with our expectations in our setting. So example here, change concept is support patients with self-management. Ideas for testing, use brief action planning at a clinic visit, try patient engagement techniques, known techniques, and perhaps use ask, tell, ask. That's just 3 simple ideas for testing within that concept. So a change package is where we take these concepts and ideas and put them together, and the change package helps keep the effort focused on the objectives of the aim statement, as well as aligned with our measurement strategy. So we're talking today about integration of self-management support into practice using improvement, and it's important to have a starting place. So this model is proven ideas. They're based in research, as I mentioned. They follow clinical guidelines, and also there's some experience and best practice involved in creating the change package. So that means they've been tested in many settings, as I mentioned, different contexts, and also by different people in various roles. So this gets put together and tested with a lot of perspectives, with a lot of contextual variables that may be different. But these changes in the change package are known to bring about improvement if tested and applied. We actually have a self-management support change package based on the step care model. We're going to talk a little bit about it today, and we're going to send it out in follow-up to this webinar. But this change package describes one approach to designing a care system that can provide self-management support within a broader goal of person and family-centered care. So that's where it sits. And it has the one for self-management support in the step care model has 4 design elements: leadership support, organizational systems, care partnerships, community linkages. And each element has its own concepts, changes, and examples. So you can take it, look at that and get right down to the practice level where you might have ideas to add to that.
So I've got, as I mentioned before, I've got this bird outside my window, and it's definitely not going through a PDSA cycle. There's obviously no planning. It keeps coming back and trying to get in my window. And it's just acting, and it's just doing. It's not studying. That it seems to be a problem that it can't get through my window. And really, the PDSA cycle is a distillation of the scientific process for creating new knowledge. And this bird is obviously not building new knowledge. It's a systematic series of steps for gaining valuable learning and knowledge for the continual improvement of a product or process. The plan, do, study, act cycles test a change quickly on small scales to see how it works, and then refine the change as necessary before implementing it on a broader scale. If this bird could figure this out, he'd probably have a whole bunch of buddies, and they'd be all swarming in like Alfred Hitchcock movie and giving me a really bad time. But obviously, he's not got that far. So if we look at the next slide, and this is an interesting slide in that it's sort of starting at the top down, and change packages can be used in many ways. So a good change package has multiple layers. You start with the concepts or principles, the vision, the idea that you want addressed that might be more vague and strategic, and then you work that down to specific steps and ideas that are very concrete and could work in a specific system. So in this slide, we take the example of the design principle, create a patient and family-centered system. This sounds very much like create patient medical home, and see how each level gets more and more concrete until we have a testable idea. In the week of November 21st, we're going to test brief action planning in a group in Comox. So, you know, rather than being able to take things, you know, here we have an excerpt from the self-management support change package. There's the change concept of ensuring the team's SMS activities meet population needs, to the key changes, and you can see 4 of them there, to specific examples that are testable on a PDSA cycle. If we look at the next slide, we see that as one example of this, many healthcare systems have used lean tools and methods as a way to improve their system. And just to sort of explore that a little bit, an important approach in lean is to look at waste. So waste might be defects, products or services that are out of specification that require resources to correct. Could be overproduction, producing too much for a product before it's ready to be sold or consumed. Waiting for the previous step in the process to complete. Wait times for referrals, consults, investigations are examples. non-utilized talent, employees that are not effectively engaged in the process. In the medical field, and in my world, certainly medical office assistants are a prime example of that. That is a key thing that needs to be worked on and improved, how they're functioning and being able to be more effective. Transportation, transporting items or information that is not required to perform the process from one location to another. Inventory or information that's sitting idle and not being processed. Motion, people, information, or equipment making unnecessary motion due to workspace layout, ergonomic issues, or searching for misplaced items. And finally, extra processing, performing any activity that's not necessary to produce a functioning product or service. So on the next slide, we can see that this can be the same as the lean approach of value stream mapping, but patient journey mapping approaches it through the lens of the patient, family, or caregiver. And, you know, we've actually worked on a project through another group that I'm working with, looking at provincial recruitment and retention by developing a physician journey map. So journey maps don't have to be developed just for patients. They can be developed for people inside the system as well, and looking at how they move through the system and what better processes could be identified, and linking those points in the process to tools that might be of assistance. The QI team maps out a process in their setting that follows, in this example, the patient through the system. And this works best when the patient, family member, or caregiver is also on the team. So let's walk through a couple of examples of changes that can be tested that would be based in self-management support concepts and key changes. So if you remember from our pyramid in the beginning, one of the items on the foundation of our pyramid was the health and literacy. So here's an example for creating a PDSA for communication, plain language. So the idea that in this case is being tested is plain language materials. The objectives are very simple. Let's make our blood pressure brochure easier to understand. And then there's a question there. Can we create a brochure for our clients that they like and understand? Now, one thing that's not highlighted in this is, why are we doing this in the first place? And presumably, we have some understanding that would lead us to a belief statement like, we believe that our blood pressure brochure isn't very easy to understand at this time, and we've heard from our clients that this is so, and therefore this is what we're going to try to tackle. So looking at the next slide, we then are saying, okay, well, let's make a plan here. So in this case, our fictitious person that is a jack of all trades, Carol, will use the plain doc checklist to make a new draft, and my computer just died. So I'm not able to see what's on the screen, John. I apologize for that, but I'll keep talking because I've got another computer going. Oh, I'm back up again. Something hiccuped. So Carol in this place will use a plain doc checklist to make a new draft of the existing pamphlet. And she's going to share it with 4 clients in her wellness group that they run on Wednesdays, and ask them to rate it for understanding and satisfaction. Very specific. There's got the when, it's got the who, and it's got the way that it's going to be measured. So the whole component of being smart is there. How she's going to collect the data is she's going to rate it using smiley faces. And the prediction out of this, what I think is going to happen, is that their clients of this clinic or this group will like the new pamphlet better and understand it. And, you know, if we look at the next slide and looking at what John had alluded to before, with going around with a pen and a piece of paper, or a pencil and piece of paper, you don't have to be complicated here. We want to collect useful data, not perfect data. We're not researchers. So keep the measurement simple. And we're using qualitative data feedback rather than waiting for quantitative data. We're using observation where it's appropriate. And we're trying to collect enough data to be able to make a decision once the change has been tested. So what decision might your group make based on the data you would get from this survey would be the question that would be asked. And if an example in this case is consistently you get I agree and strongly agree, then the new brochure is working pretty good, and it may not have to be tested much more and might be ready for release. Whereas if you get results back that are towards the left end of the scale, back to the drawing board. Carol has more work.
Yeah, Bruce, I was just going to go back to your point about keeping it simple and also using the qualitative. And I did help develop some programs for chronic disease management patients. And we thought, well, we need to look at what the outcomes will be. And so, you know, we better get a professional evaluator in to create something for us. And PhD person, a person with a wealth of experience, and they came back to us with 3 questions with the same scale, and it pretty much mirrored what you all see on your screen. It was from the participant, patient, client perspective, what was their perception of the value of the different components of our program. And that was a really big aha moment for me, if I could even use that phrase. I just went, so, and I questioned her and I said, is this what going to give us the information we need? And she said, you told me what you needed, use this. And we did.
And you know,
oh, go ahead, Bruce.
Yeah, and you know, I think the interesting thing in this is to remember, and I was involved in a project that was very much like this, but instead of blood pressure was dealing with heart failure. And the key thing, as was mentioned earlier, is involve the patient and the family in those kind of communication, plain language type of projects. Get their input, have their feedback early on, make sure, as we often do, we assume that we're speaking a language everyone understands, but so often it is something we're used to, but the patient isn't used to.
Mm-hmm. Let's look at a couple more examples. I mean, that's often what we get a request for is, tell us, give us examples of what exactly we can do. So looking at this one, a PDSA, again, for communication, but talking this time about teach back. So what is the change we're looking at here? It's the approach of using teach back. And the objective for a test could be to use teach back when providing information about physical health. So it's pretty specific. What questions do we want to answer with this testing cycle? Can we use teach back when talking to clients about healthy lifestyle? Will clients like it? And will staff think it's worth their time? So PDSA can be short and simple and precise, but still answer more than one question. And that's really important. When you're talking about what you could test with your local care team or your group, your practice group that you work with, what are the questions that this test will answer? Helps you line up your prediction. So then the plan here would be to answer your questions. And specifically, Jim will use teach back on Tuesday, so one day when he talks to one client, about our risk factor, lab test, or going to the doctor. And then there's a plan for the collection of the data. Jim will track how much time it took and note if the client was actually able to state the key points of the conversation. Prediction, very important. Bruce talked about this earlier. The prediction is it will take about 2 minutes and add that to the visit, but it will be to the benefit of the client.
And such a key thing about teach back. When I started using it in my practice with patients, what I was blown away by was how often, when I thought I'd done a wonderful job explaining something and gone into all the detail, all the patient heard was a couple of key words and maybe the first sentence. And when I respectfully asked about what it was they heard by turning it back on myself, just so that I understand what is it that you have gained from this conversation, that 9 times out of 10 patients didn't get some of the main points. And it was a very valuable process to just test that out, to understand why we're doing this. So I'm going back to one piece that isn't in each of these little examples that we're getting. Why are we doing this in the first place? And I think that's the key thing to convince people to market your project, is ask the question why. And it's like that Simon Sinek TED Talk or YouTube video, start with the why.
Mm-hmm. I don't know if I added that to the reference material, but that's a good book to check out, Bruce.
Yeah.
All right, let's look at a third PDSA, plain language handout. So yes, I help people all the time test a new document or handout or something that's going to be used for education. So in this case, it's serving size handout for a healthy eating group. And the objective could be use plain language version of health information related to this handout. And what question or questions do we want to answer with this cycle? Will clients like the plain language brochure? So Cheryl will review the portion sizes brochure with the healthy eating group before they eat lunch. And that's going to help answer the question that was laid out. Then the plan for collection of data, Cheryl will ask the group if they like the pamphlet and observe what they eat and discuss this during lunch to see if portion sizes are considered. So you see, this addresses a bunch of things. There's some qualitative in here. There's some data that helps you answer the question, and will let you know about your prediction. And it's also just direct observation of what's happening as well. So there's a whole bunch going into just what looks like a simple data collection process. The prediction is the pamphlet has too much information on it and that no one will pay attention. So in this case, it's been developed, and the prediction is that it won't be liked or used in the way they thought. So the group has obviously decided this will be the content, but they can quickly test it, take that, do the study portion, and say, did it satisfy our prediction or not? And if it did, then they would then do cycle number 2, make some changes and adjust their approach again. I really like this example. It's got such a sophistication to it, and often people will say, well, let's just give the handout, it's got the information we need. But in this way, you can just really do some rigorous testing, and the goal, of course, is to learn about what you're doing, and this lays it out nicely. Okay, so I kind of alluded to this, where you often don't find out all about your change and what improvements it can make, and what the effect will be on your system by doing one cycle. You often don't know enough to say, yes, we have enough information to say that we can implement this. Sometimes you do, but often you don't, especially when you take something that everybody around the table says, well, this might be a little more complex. So let's walk through how this might, the whole thing might fit together. Looking at this, using multiple cycles to implement patient and family-centered resources into practice. The key change here is user-developed tools to facilitate person and family engagement in self-management support. So the question at the beginning, the overall question that can guide the aim, can we create written materials our clients like and understand? So in cycle 1, you test one brochure with one patient and get some feedback. Cycle 2, you've learned something, you can revise the brochure and test with all patients through one day and measure the effectiveness. So in this case, maybe they found that 35% of patients found the brochure or information that it contained irrelevant and or information they already knew. So as Bruce mentioned before, you go back to the drawing board, you do some revisions based on that new knowledge, and then you do cycle 3. So they tested several revised patient brochures, but with all patients and in a week. So you're pretty confident, your level of confidence that the new changes is going to be an improvement is higher because you've already tested with a couple of groups on a small scale. Cycle 4, go ahead, Bruce.
So I just wanted to interrupt you in there, John, because I think there's a relevant question here from Trudy. You know, 2 questions actually. One is, how can we know if the new brochure is better than the previous? And I think that Trudy sort of addresses why are we doing this in the first place. Presumably, there's been a cycle initially of feedback where you are understanding that there's some problems with the first brochure, and so you're going to try out something new. That was, you know, the why are we doing this? How are we going to tackle it? And what are we going to produce? It's that why to the what that Simon Sinek describes. And again, and your second question is, how do we know that the brochure was not useful? And John, maybe you could answer that one.
Right. So if you think back to the example, the PDSA of the handout, they actually put it forward, had a prediction on how it would work, and had some ideas about what the purpose was, as you mentioned, Bruce. And they could use observation, or they could use a quick survey, just even using happy faces from the users. So you would try the brochure, and then you would ask the person some relevant questions that would give you the feedback. And in cycle 2, in this case, it's not on the slide, but said they tried it with all patients through a day to measure the effectiveness, and you would use some scale of effectiveness or a couple questions, and 35% found some of the material in the brochure irrelevant and or information they already knew. So that's where you can tie it back to the lean approach that Bruce was talking about. So there's some wasted effort, some wasted information, and you're looking at getting rid of that waste. So the brochure, perhaps the feedback was that you didn't need all of the information in it, or you needed different information. So they revise it based on that and then test it again. Great questions. And you can,
there's some other, and Troy, just as I mentioned to you in here, there's other questions from Roseanne and from Holly that for whatever reason I can't see that may be relevant. So I'm not quite sure what's going on with our process here, but I could see Trudy's question and now no longer can see any questions.
They're just
so
background questions.
Oh, okay.
Audio and whatnot.
Okay.
But yes, please, we encourage you all to type in the question box if you have any. And Bruce, it sounds like you can see them, or Troy can forward them to us.
Yep. Sorry, go ahead, John.
Yeah, no problem. And in this case, they actually conducted 5 cycles, and it's all related to the same change, okay, the same thing, but they're revising, learning a bit, and doing a new cycle. And in cycle 5, implementation was done, but implementation on a test basis across all of the services at one time. So you have a fairly high degree of belief that this is going to work because you've gone through revisions, feedback, learning, and a bunch of tests already. And then at this point, you're still occasionally doing some testing, but it's more related to the monitoring of the effectiveness. The monitoring system is put in place. So you're still checking in once in a while to see that it still has the same level of effectiveness. Because as we know, things can change in clinical practice, or your patient panel can change. And so you still want to be doing some ongoing monitoring. All right, this is just capturing again what we talked about, looking at the quick review of the overall improvement process. So you're doing this so that you can do sequential, very small step building of knowledge. And that knowledge is meant to align with your theory. If we integrate the step care model into practice, is it going to have the effect, overall, measurable effect for our patients and clients that we predict? And you want to include, as you go up the ramp here, testing these approaches and skills and tools in a wide range of conditions through a sequence of tests. And I had mentioned at the bottom here we have some theories, we have some best practice, we have some evidence, but we also have some hunches of where to start. And it's all in relation to what our overall aim is. And then going through the ramp and the testing is just about us learning how this is supporting or refuting our theory. So the easiest thing, if you get stuck on what to do next, is just go back to what you laid out in your original theory, which is written down in your charter. And in that, you'll say, who is this for? What are we trying to accomplish? How will we know that the change is improvement? And you'll have your measures right there. And then what changes can we make that will result in an improvement? And we have a few minutes left, but I did want to say that quality improvement work is just, well, it's simple and it is collaborative, and we can do it with the patient-centered perspective. The small steps, deliberately and persistently over time, testing and learning is how we get this done. And I know there's probably some proverbs and phrases and sayings that align right with that, but there really isn't any other way to integrate these overall system transformational models into your work. We would love to make the big leaps, and Bruce, maybe you can talk a little bit, because I'd really like to go back to what you said about this. Putting this into practice was transformational for your practice.
Yeah, I think in just sidestepping that just for a second, because you heard me say it, and I'll say it again very shortly. But key to what we're doing here is understanding and answering what the question is, the why, so that you can engage others, and having some belief statements about what it is that you believe about the why is key. And then when you are starting to get to the how and what, really consider those 5 points that we made earlier, that it's practical, that it's meaningful, that it's clinical, there's a value proposition hopefully involved in it, and key is that success can be measured. Those are 5 key principles that really will ensure you being able to know whether or not what you're doing is improving or not. And as I said before, yes, this approach does slow down your time, your day somewhat. The value that you get out of it, the satisfaction that you as a person and the people that you're dealing with get out of it are just phenomenal. I can remember deciding to do brief action planning and recording it, and had a teacher that I was doing brief action planning with, and he stopped and looked at me and said, "You're doing an individual education plan with me, aren't you?" And I said, yeah, I am. And he smiled and said, "Okay, let's go for it." And that was the kind of thing that you realize that you're starting to engage patients when they recognize what you're doing, and that this is a PDSA, that you are trying something new, that it is self-management, and they appreciate it. So, there's my little story and my plug that says just go out and try something, and keep it small, practical, meaningful, clinical, value proposition if possible, and measurable.
Thanks, Bruce. Troy, did we get any more questions? We've got a couple minutes.
No questions as of
Nope,
yet, but we could give it another minute.
Sure, we'll leave it open for questions. I don't need to stick on this slide. I'll just give a couple reminders to people. So yeah, we'd like to strongly encourage you to explore the improvement approach to putting your self-management support approaches into practice. And there's lots of ways to do this. There are coaches at CCMI and resources on the web page. So reach out and ask for help with questions that you might have. Quality improvement and applying it is really like any other skill that you might learn and practice. So we talked about the many small steps, and it's very action-oriented. So you're actually doing something to learn, but it takes practice. And a reminder about the next webinar, where we're going to look more at the measurement, but measurement for improvement and measurement for evaluation in relation to your self-management support efforts. And I'll be delivering that one next week at the same time. Troy, anything coming in question-wise?
No other questions?
I don't see any.
Yep. We'd just like to thank everybody for participating in this call, and hope that you will take pencil to paper and try your own improvement project, and love to see it being around self-management support. It fits well with the direction that we're headed in this province. So thank you very much, everybody, from myself and John.
Yes, thank you.
Thanks,
Back
everyone.
to you, Troy.
And take care. Enjoy the rest of your afternoon, everybody.
Bye all.
Bye all.
Bye-bye.